reduced my talk to fit for the time to only 150 slides. It's usually to cover that we need more and more, even the doubling. My talk will be presented by the first slide, and here is anemia management in CKD, ESA, and beyond. If you look to the ESA terminology, it will disappear few years later because there is introduction of a new molecule, which is hypoxia-inducible factors. So it is probably within the next years, we have two terminology for the ESA to differentiate between that erythropoietin hormone replacement therapy and hypoxia-inducible factors, prolyl hydroxylase inhibitors. So this is my first insight on the talk. ESA components has two components, one of the erythropoietin replacement and the other is the new introduced molecule in the treatment of anemia. We will cover both of them. So the agenda will be covered here is the CKD and anemia, EPO function and EPO receptors and soluble EPO receptors, controversy in optimum anemia management in CKD and the current guidelines with future guidelines, EPO transfection and production techniques, hypoxia-inducible factors, physiological pharmacological function beyond even anemia treatment. And lastly, beyond ESA, we can discuss a lot of the L-carnitine, B12, folic acid, and the others. If we look to the impact of chronic kidney disease and anemia with health-related quality of life and the complications of anemia in patients on dialysis and CKD from the multinational real-world data, you can find that lower hemoglobin levels worsens the impact of CKD, health-related quality of life, and are associated with lower work productivity in patients with CKD. The physical properties as well for patients with anemia and CKD, hallmarks of the impaired of their physical activity, exercise tolerance, and monitoring and managing the daily life are impaired in patients with anemia and CKD. The comprehensive outcomes of anemia in US with patients with chronic kidney disease is well known. On the other hand, the cause of anemia in CKD is multifactorial. We understand that decreased erythropoietin production. We understand as well the uremic inhibitors on the bone marrow and the red blood cell survival. We know that there may be as well inflammation and hepcidin level is high. As well, sometimes in many patients, we can find occult blood in stools and GIT hemorrhage. In some sectors of patients with anemia and CKD, the cause of anemia is beyond the kidney. For example, multiple myelomas and polyclonal and monoclonal gammopathy. So this is one of the hidden causes of anemia that we have to search. Is the hemoglobin level is below the estimated GFR, for example, if you have estimated GFR stage 1 or 2 and the patient is truly anemic, beyond we have to think about causes rather than CKD and erythropoietin. In chronic severe anemia, the probability of heart failure is high. We have a lot of mechanism on that. We have the peripheral vasodilatation, decreased blood pressure, especially the diastolic pressure, increasing neurohormones, catecholamines, rest, and others, decrease renal blood flow, so it is the vice circles, increase in salt and water retention, extracellular volume, plasma volume increase, and ultimately left ventricular hypertrophy and dysfunction. On the other hand, in patients with heart failure, has a chronic inflammatory disorders, so aggravating the anemia and aggravating the therapy with resistance. So this is traditionally the flow chart for evaluation of the CKD patients with anemia. We have to determine the CKD stages, if we have a CKD below 3P and we have to check other causes of anemia rather than the kidney, we have to make a workup, which is the iron deficiency have been treated first, and blood loss, hemoglobinopathies, vitamin B12 and folate should be suspected. And if this is iron deficiency, we have to treat the iron first before giving therapy. Anemia and iron deficiency, in other words, what is the outcome and the practice pattern study? It is unmeasured. Hemoglobin and the iron store are measured less frequently than per the guideline. And it is estimated that nearly half of patients did not discover they are anemic in the pre-dialysis stages, with huge variabilities in between patients, in the percent of patients between the hemoglobin arrived. For example, you have a huge patient in the below 9 and up to 13. So this is huge variation in the hemoglobin in the pre-dialysis stages. Whenever there is dialysis and the patient is anemic, it is a very painful dialysis because the patient will not tolerate huge anemia, difficulty in maintaining patients within a narrow hemoglobin range, and the tolerability and the variation of hemoglobin has a worsened outcome. Appropriate administration of ESA with regard to safety and efficacy profile, monitoring frequently of hemoglobin, cost-effective, and improving the comorbidities. So patients who started hemodialysis with anemia usually are intolerable to the treatment of dialysis, has frequent complications, heart failure, and higher mortality. So pre-dialysis in CKD anemia management program should be installed early. Erythropoietin is essential to the production of red blood cells because it's required for survival, proliferation, differentiation of erythroid progenitors cells in the bone marrow. This is a basic. Human erythropoietin is 30 kilodalton glycoprotein composed of about 165 amino acid residues. The kidney are the primary, but not the only, source of EPO. Its synthesis is controlled by hypoxia-inducible factor, and we will come to this slide in more detail. The hypoxia-inducible factor, naturally in physiology, will increase the production of erythropoietin whenever it passes through the renal tubules. And the renal tubules consume about 90% of the oxygen delivery to the kidneys during sodium reabsorption in the renal tubules. So the kidney tubule is very sensitive to hypoxia, with the stimulation of erythropoietin largely increased with hypoxia. The three main sources of EPO production in mammals are the cerebral, the hepatic, and the kidney. All are in the same line, but the kidney is responsible for more than 80%, and the remaining part from the liver is increased in supraphysiological stimulation by hypoxia-inducible factor proline hydroxylase inhibitors. So hepatic EPO can be upregulated by pharmacological treatment stabilization of hypoxia, but in normal physiological, the kidney is responsible for the major development and production of erythropoietin. So regulation of endogenous erythropoietin gene transcription by oxygen-sensitive hypoxia-inducible factor pathway in the normal physiology during normoxemia, there is suppression of the proline hydroxylase enzyme, so hypoxia-inducible factor alpha is suppressed and it is degraded. However, in hypoxemic stages, there is high hypoxia-inducible factors production with inhibition of proline hydroxylase inhibitors, subsequently increasing in the gene transcriptions and EPO production, which is stimulated by hypoxia when reaching the renal tubules. EPO as well has a pleiotropic effect on different other organs rather than the red blood cells, we have erythropoiesis, we have a brain protective against ischemia injury, which is a target nowadays for treatment by hypoxia-inducible factor, come later. It can contain the vascular tool, inducible nitric oxide, the heart against ischemia, the myoplast, wound healing, white fat, protective opacity, and bone remodeling. So erythropoietin receptors are presented in many organs rather than the red blood cells in the bone marrow. It may have additional factors and additional effects. What is the EPO receptor and soluble EPO receptor? Because it's a new insight for treatment and understanding that the rule beyond the erythropoiesis, the erythropoietin receptor is a member of type 1 cytokine receptor superfamily. In addition to the erythroid cell, there are other cell types that express the EPO receptors, as discussed, the heart, the kidney, the brain, the liver, and others. Vascular endothelial cells, astrocytes, neurons, cardiac myocytes, retina, and others are also have the receptor. So we can expect that erythropoietin has a physiological control of this organ besides its hemopiesis effect. So the erythropoietin receptor, it controls the proliferation, maturation, and also survival of erythroid progenitor cells. Soluble EPO receptors is related to EPO resistance in CKD. So if we have a soluble EPO receptor that attracts the erythropoietin molecule, we will have dysfunctioning erythropoietin. Even we can have high level of erythropoietin due to increasing of their soluble EPO receptors in the blood in patients with CKD. So EPO receptors beyond erythropoiesis can be functioning in the brain, in the heart, improvement with association of decreased apoptotic cell death, as well in the kidney, and it's a protective effect with associated with a decrease in apoptosis and cell death. Erythropoietin as well improving the memory, synaptic conductivity, neuroplasticity, proliferation, neurogenesis, and long-term potentiation. It has inhibitory effect on the inflammation, apoptosis, and oxidative stress. How it works, we have to see the function from the start of the sequence of events with hypoxia. By 1 gram of oxygen can carry a significant number of molecules of oxygen. So if we have a chronic kidney disease with decreased production of erythropoietin, we can have an idea about the hypoxia that the tissue suffers. One of these factors is decreased red blood cells production. However, with hypoxic effect by low hemoglobin in CKD, all the organs suffer and stimulate in hypoxia-related sequence of events and a very huge proliferation inflammatory cascade. What is the compensation of low hemoglobin? That's what we understand years before the oxyhemoglobin dissociation curve and shifting to the right and the left, and its affinity to the low oxygen tension, example in high altitude. So whenever there is middle or lower range of oxygen, increasing affinity of the hemoglobin inside the red blood cells, and whenever there is plenty of oxygen, they can contain a lot of oxygen and deliver it to the tissue. What is the normal physiology in hypoxic state? They can compensate by more delivery of oxygen to hypoxic ground and cells. The mechanism of EPO production is related directly to the sodium reabsorption in renal tubules, where it consumes 90% of the oxygen delivered to the kidney. Whenever there is low hemoglobin and hypoxemia, it stimulates the EPO-producing cells. However, in some cases of inflammation, the inflammatory cytokine has both directional ways. Number one, reducing the erythropoietin production. Number two, it has a huge suppressive effect on the bone marrow and the iron delivery. So in patients with septicemia and bacteremia or inflammatory reactions, we have a bidirectional inhibitory effect of the bone marrow and the EPO production from the kidney. The balance between hemoglobin and the treatment should be in a very narrow window, because if we go above, for example, 12 grams per deciliter, we have major advanced cardiovascular events, thrombotic manifestation, pulmonary embolism, and if we have a lower target hemoglobin, we have more blood transfusion and impaired physical and quality of life. So this is a very narrow gap and window between the risk and the benefit. And it's completely individualized for each patient. The end point for treatment is the risk of mortality and the quality of life with progression of end-stage kidney disease. Patients on dialysis may suffer from vascular access thrombosis. So it is a wisdom that to give the erythropoietin stimulating agents and hypoxia-inducible factors in a very narrow range of safety and efficacy. The proposed mechanism for cardiovascular events at higher target hemoglobin, increased blood viscosity, improved platelet function, and more margination, thrombocytosis, as well hypertension with increased red blood cell volume. So the clinical implications, what is cons and the pros? It reproduces deficient native hormone if you are giving the erythropoietin directly, effective in most patients with tolerance. In most patients, 30 years of experience, IV administration invisible to hemodialysis patients, while in CKD you are giving subcutaneously, long-term cardiovascular events, ESA resistance, pure aplasia, and others. Lessons from the clinical trials for the erythropoietin replacement is huge data on the internet, and the guidelines saying that it is between 10 and 12, which is the red zone and the gray zone of clear benefit with no evidence of risk, while increasing this level above 12 grams, there is increased risk without additional benefit. The patient will not get benefit if the hemoglobin target higher than 12. So the risk is viscosity, hypertension, pure cell aplasia, and cancer. We'll discuss it in more detail in a few minutes. The benefit is important for tissue oxygenation, decrease inflammation directly and indirectly, mental performance, quality of life, and fewer transfusions. So high dose ESA requirement among CKD participants was associated with elevated inflammatory biomarkers, which is the resistance to ESA function in the bone marrow and the maturation of red blood cells, as well as the soluble erythropoietin receptor as an inhibitor of erythropoiesis. So this is my first insight that of the erythropoietin molecule, erythropoietin receptor, and soluble erythropoietin receptor. What is the perspective for treatment? There is 3 hypoxia-inducible factors we'll discuss in details in the second part of my talk, as a global development program that have sought or will soon seek approval. That's why the ESA terminology may change during the following years into 2 parts, erythropoietin replacement therapy and hypoxia-inducible factor. In the DOPS and the other and the KDIGO guidelines, it's 10 years without hearing from the KDIGO on the anemia management. It is the same, just an summarizing that patients below 10 grams and above 12 grams should be considered that not fitting, either for low hemoglobin level and higher hemoglobin level and the rest. That's why the last year, the controversies in optimal anemia management conclusion from kidney improving global outcome KDIGO highlighted that we need an update for the anemia management. And this re-examination of previous recommendations. In 2019, KDIGO decided to convene controversies. Second controversy discussed more specifically related to ESA and hypoxia-inducible factor introduced recently to the market. So this is the global and the scope of the work. They think that the terminology may be changed to erythropoietin hormone replacement therapy to distinguish from hypoxia-inducible factor, which is under the ESA therapy, by the way. What are essential elements for treatment, distinguish hard outcomes, surrogate outcomes, patient-centered outcomes, complications, hospitalization, and cardiovascular risk. So we expected that within the following year that KDIGO will publish new guidelines. What is the route of ESA administration? What is preferred type by each patient? And what is the nature of hypoxia-inducible factor, prolyl hydroxylase inhibitors, and their strategy when to shift from ESA to HIF and to the reverse, and what is the dose we should play on that. This is driving that higher hemoglobin is associated with development of complication. And if you look to the guidelines, all of them are currently in the range between 10 and 12 grams per deciliter. While in our Egyptian guidelines, that I was honored to be the editor of this guideline, we said clearly that patients' hemoglobin should be between 10 and 11, looking for no more benefits for above 11 and less complication and the cardiovascular risk, thrombosis, and other strokes. Hyporesponsiveness, we identified in our guidelines if the patient needs epoetin dose subcutaneously more than 300 international units per kg per week, or darpoetin dose more than 1.5 microgram per week per kg per week. And also, we identified the possible and the modifiable and potentially factors involved in ESA hyperresponsiveness, including dialysis adequacy, inflammation, malnutrition, deficiencies of iron, vitamin B12, folate, hypothyroidism, hyperparathyroidism, and the use of race. What is the global? You can see that from the graph, a huge variation in between patients on dialysis in the hemoglobin level between below 9 and above 13. And most of the patients taking the ESA route by IV during dialysis, although it costs 25% more than the subcutaneous route, but for patient convenience route. The same in Canada, as well in the Gulf Corporations Council. So we have already huge variation between patients' hemoglobin on dialysis. Coming to the next part, what is the role of the erythropoietin stimulating agent in patients with CKD and cancer? A clinical approach. Persons with CKD with remote or active malignancy should receive the lowest ESA dose possible that achieve a maximum hemoglobin level of only 10. So the first question to ask in patients with malignancy giving ESA, we accept hemoglobin 10. Why we are afraid from ESA on that way? Let us look back to the pathology, what happened during malignancy. Growing malignant cells develop extra manifestations, extra cells with consumption of the oxygen inside the malignant tumors. Subsequently, in order to achieve that and survival of cells in the malignant way, they produce a lot of angiogenesis substances that increase directly the blood supply. And this is the worst case if you are using ESA and HIF. They increase the angiogenesis by itself. And if you look in deeper that, malignant cells, HIF and ESA, introduce a metalloproteases that distract the extracellular matrix, increasing the vascular endothelial growth factors. And this vascular endothelial growth factor increasing the permeability of the endothelium. And this part is important for malignant dissemination. So we have two arms of the ESA and the HIF. In case of malignancy, they induce angiogenesis and they increase the vascular endothelial growth factor, making more dissemination of the malignancy. So ESA and cancer could increase the progression. The question is yes, but with precaution to the type and the stages of the malignancy. The supraphysiologic hemoglobin level are used in most clinical trials. The binding of APO to macrophage as well can suppress nuclear factor kappa activation and pro-inflammatory genes, resulting in an immunosuppressive effect. So using ESA directly and indirectly can affect the prognosis of malignancy, especially if it's active. Besides that, it increases the thromboembolic events in cancer patients and induce huge angiogenesis that may increase the cancer dissemination. While in patients with CKD who has malignancy and anemia, we can follow this flow chart. So if the patient has no history of cancer, proceed regularly. But if the patient develops cancer, it depends on the hemoglobin level. If it is sharp drop of hemoglobin, give blood transfusion prior to ESA evaluation. But if the cancer is considered cured, consider continuing. If not cured, follow goals for active cancer. Be aware that ESA may increase the progress, and number two, the target hemoglobin never be in malignancy above 10. The CMS Center for Medicare had applied a strict rule for that ESA is not beneficiary for most of the clinical condition because of the deleterious effect of ESA on the underlying disease or underlying increase the risk of adverse effects related to ESA use. However, it is indicated in some malignancy and it is not indicated in others. If you can see it, not indicated if you have a folate deficiency, B12 and iron, or in bleeding state, or it's related to myelomas, it is related to chronic myelogenous leukemias. The anemia of cancer is not related to cancer treatment and prophylactic use to prevent chemotherapy, while it's strictly indicated in some types of myelosuppressive anti-cancer therapy. So any patient with cancer, when prescribing ESA, we should look carefully for the prognosis and the adverse events of ESA. To our clinical practice, to the second complication of ESA is hypertension. And the arterial hypertension induced by erythropoietin is a multifactorial. And just to summarize that, it is nearly most of patients develop hypertension besides one of the causes of hypertension in patients with CKD on dialysis. The mechanism related is due to many factors. One is increase in endothelin release, and number two is a decrease in endothelial nitric oxide production. So if we reduce nitric oxide production, increasing the systolic and the diastolic pressure, with no difference in blood pressure response between any or ESA type, either short-acting or darpoietin. So SERA and darpoietin and ESA has the same mechanism of hypertension and incidence, and it is related mainly to effect of them on the decreasing in nitrous oxide and increasing in thromboxane, insulin 1, while affection directly related probably to the endothelial cells. In dialysis, intradiuretic hypertension is aggravated by administration of ESA during the dialysis. So patients develop hypertension with ESA need consulting the dose and the target hemoglobin, and we can shift it to lower dose and giving more antihypertension if other causes of hypertension is excluded, like salt and water retention, volume overload, and others. What is the component EPO? How it's produced? We have to understand that as a nephrologist. You can have a small molecule drug in the site. You can have larger molecule in the site by biology, and you can have even immunoglobulin therapy. And this is the functionality and the complexity. It's like a bicycle, and if you have a large molecule, it's like a car, and you have a huge molecule and the functioning, it is like an aeroplane. The complexity of EPO formation is related to a terminology called transfection. And transfection is the human EPO or cloning DNA coding sequence are transfected into another eukaryotic cell. So let us see this, how it's produced, and why we can find variations in the performance of some types biosimilar erythropoietin than others. Cloning of the gene inside eukaryotic cells in erythropoietin releasing cells, it is usually Chinese hamster cells, and this introduces the cloning gene inside these cells, usually by lipids or other means of incorporation, and this lipid-based reagent introducing the gene inside, functionality then applied to the nucleus to produce the EPO. And the hormone or EPREX are the same sequence, even the darpoietin are on the same way. However, after such a transfection procedure, you need a huge stages of purification. So on the same side of production, if you are inducing in mammalian cells like erythropoietin, it's usually the hamster ovarian cells, and if you are using transfection on the bacterial release like growth hormone, calcitonin, and insulin. And both of them are called transfection of the gene inside eukaryotic cells. So the difference between current erythropoietin, it is depending on the carbohydrate cell, the same amino acid sequence for erythropoietin alpha and beta, but it is different for darpoietin. The darpoietin or congeners of erythropoietin mutation has increased in size 37.1 kilodalton and increase in the carbohydrate. Coming to the third part of my talk, what is the hypoxia-inducible factor activation? 3 hypoxia-inducible factors, the daprodustat, roxadustat, and vadadustat, have global development programs that have sought or will soon seek approval. How it works? Let us imagine where we are. If we are in Boston, we are on the sea level, there is no hypoxia and oxygen tension is 20%. If you go up, like Chamonix in France, or Aspen in US, or Mont Blanc in France, you got an oxygen 11%. And if you go higher, like Everest, you have an oxygen content is only 7%. And this variation in the oxygen content and hypoxia is a huge stimulant of hypoxia-inducible factor, prolyl hydroxylase, that inhibits naturally the hypoxia-inducible factor. Whenever there is hypoxia, there is increasing in the activity of prolyl hydroxylase inhibition, destruction is limited, and increasing in hypoxia-inducible factor molecule that induce the erythropoietin release from the kidney as well from the liver. The essential mediator of cellular oxygen signaling pathway, it is a heterodynamic transcription factor, oxygen sensitive molecule, which is the active molecule, the hypoxia-inducible factor alpha. It can control as well what is called compensation of the hypoxic field into different other way, not only for erythropoiesis production. It controls glucose uptake, metabolism, angiogenesis, erythropoiesis, cell proliferation, and apoptosis. So hypoxia induce larger amount of hypoxia-inducible factor by inhibiting the prolyl hydroxylase, which naturally destructs the molecule. The roxadustat and the other molecules can also controlling the cytokines, lowering the hepcidin, and improving in the iron absorption. Hypoxia-inducible factor from theoretical to superiority to clinical non-inferiority, we can find that the new drugs of hypoxia-inducible factors here that introduced in the market and launched in Japan, China, and some other countries can increase the production of internal erythropoietin directly from the kidney in the supraphysiologic dose, as well from the liver and others. However, it covers a huge metabolic control of other systems. Some of them are beneficial and open the door for new therapeutic challenges of the hypoxia-inducible factors molecule for others. It's controlling the mitochondrial function, the angiogenesis, probably in ischemic skin and the others, the metabolic changes, the fat tissue. It inhibits the hepcidin and the inflammation pathway. It can improve the wound healing and fibrosis. Be aware that increasing the erythropoiesis is one part of the big puzzle of HIF can do. While the kidney has a fibroblast-like renal erythropoietin production in the supraphysiological doses, the EPO upon a second hypoxic stimulus. So the main function of HIF tablets oral intake is increasing the erythropoietin production from the sleeping cells in the renal tubular paratubular cells. So treatment with HIF, stabilizing agent like roxadustat, re-induce EPO expression in previously active red cells of damaged kidney and CKD. Also, it's released from the liver. And this is one of these, on the left side, you can find that in normal oxalic state, there is hydroxylation by HIF prolyl hydroxylase, so destructing the hypoxia-inducible factor. However, if we go to hypoxic stage or the treatment with HIF, which simulates the hypoxic stage, this enzyme is blocked, so increasing in hypoxia and inducible factors alpha, and this transcript a lot of genes, and these traps are affecting one part is erythropoietin. However, increasing that has many functions as a normal physiological control of hypoxia, like exactly if you have been in the Everest mountain. If upregulate receptor increase intestinal iron absorption and transferrin transporter iron to transferrin receptors, iron is released from transferrin. HIF as well upregulate the EPO receptors and endogenous EPO production. HIF upregulate transferrin receptor, increasing iron uptake by proerythrocytes in the progenitor cells in the bone marrow, and promote the formation of polyfunction mature erythroblast. That's why when in stimulating the hypoxia-inducible factor transcription gene, you have many functions. One of them is the erythropoiesis. However, angiogenesis is the mechanism of deliver more blood supply to hypoxic organs, so compensating for the hypoxia. Increasing the erythropoietin from the native damages chronic kidney disease in the supraphysiological volume of hypoxia-inducible factors is probable. So his pH inhibitors are likely to become an important tool for anemia management in patients with CKD, improve erythrocytosis, increasing in the iron absorption and transfer, and decreasing in hepcidin level. And it is well documented in most of the studies that HIF decreases the hepcidin, which is related to anemia hyperresponsiveness to ether. Other functions besides erythropoiesis, it controls the inflammation, inflammatory markers, improving the EPO response, as well as improving the bone marrow suppression by inflammation. In the immunity stages, HIF can also control the inflammation of the macrophage aggregation. Even in infection is importantly because when there is an infection, there is migration of macrophage and neutrophils from the bloodstream to the tissue, which is already hypoxic during infection. So migration and leaving the bloodstream from the blood to the inflamed part, like wounds and infection, the macrophage and neutrophils suffer from hypoxia. And here, the HIF molecule improve their function and improve their phagocytotic effect. The metabolite increasing in the glucose uptake by the GLUT1, increasing glycolysis. So it's considered that one of the inflammatory mediators controlling the hypoxia, they can compensate, on the other hand, this process and improve the tissue oxygen and delivery of the glucose. However, in cancer, as discussed previously, it is risky because it induces angiogenesis. In the bone marrow, it controls the common as well myeloid precursor cell and common lymphoid precursor cell with natural killer and lymphoblast production of antibodies. In few trials discussing the hypoxia-inducible factors in inflammation and both acute kidney injury, this one, very few slides discuss that, but it is a good insight to have an information on the reperfusion injury in the kidney and the brain, and this signaling that therapeutic approach in mouse model of renal ischemia reperfusion injury is improves that. In diabetes, it resembles that diabetes and diabetic complications, because diabetes, especially in the kidney, impaired due to insufficient activation of HIF signaling, which results from inhibition of HIF-1 alpha stability and function due to hyperglycemia and elevated fatty acid level. So this in diabetic kidney disease, it is one of the promising mechanisms that, because if you have a diabetes, you have impaired adaptive response, angiogenesis, glycolysis, migration, proliferation, and cell survival, all these are decreased, so increasing in the mitochondrial respiration. If you look to this very nice diagram, I think it is concluded that impaired response to hypoxia in diabetes contribute to the development of diabetes and diabetic complications. Look for that impaired response to hypoxia. Let us reminding that one of the mechanism of ischemic lesions in the renal tubules and fibrosis in the kidney is hypoxia. And why anemia can progress the CKD? Because the oxygen delivery to the renal tubule is affected, and it is almost 90%. And with the expansion of the renal mesangial cells, we need more oxygen. That's why improperly the new molecules of hypoxia-inducible factors can control or regress the damage of renal tubules by delivering more oxygen and the mesangial cells before expansion to have less fibrosis. So hypoxia and renal tubule is the driving force for tubular atrophy and interstitial fibrosis. Maybe both of sodium glucose cotransporter and the ACE synergistic effect on the sodium glucose co-transporter in renal tubes, and this may be an insight for new therapy in patients with diabetic kidney disease. It also controls metabolic disorders in type 2 diabetes. What about the literature written in this field? The devil in the details. Mountain of information and knowledge. We need more data. We have different molecules. What is introduced in the market for the HIF is daprodustat, roxadustat, and vadadustat. They control the trial population in pre-dialysis population, in incident dialysis, and in prevalent dialysis population. They also compare the effect of either erythropoietin directly, like darpopoietin or recombinant erythropoietin, in between them. In non-dialysis dependent CKD placebo-controlled studies, it gives a beneficial effect to reach the target. Looking for the major advanced cardiovascular event, it does not differ significantly between HIF and ESA therapy, erythropoietin. In non-dialysis dependent ESA controlled studies, there is non-inferiority in production of hemoglobin, daprodustat, roxadustat, and vadadustat. And the efficacy in hemoglobin response is identical nearly of the three types of the HIF molecules. In stable dialysis dependent population, the treatment period for the post and the primary end points for both the major advanced major cardiovascular events, MACE and the MACE plus, if you have heart failure, it shows that, for example, the roxadustat improving the hemoglobin with decreasing the IV iron use. This is one of the beneficial effects of HIF molecule. It also decreases the hepcidin level. So it could be of value in patients with hyperresponsiveness of erythropoietin due to inflammation. The complication and advanced cardiovascular events are equivalent for all groups. Additional endpoints are the same. We are looking for lower IV iron use. It decreases the LDL cholesterol changes. The arterial blood pressure, exacerbation of hypertension is better, and for all of them, the benefit effect in ESA-resistant inflammatory high hepcidin level. The complications for that, the standard, the stable dialysis dependent population, and in incident dialysis dependent population, again, is darpopoietin and erythropoietin alpha and beta are equivalent in that. So they are non-inferior to the current ESA erythropoietin treatment, and the major advanced adverse cardiovascular events and the MACE plus, like heart failure, are equivalent and not inferior to others, with the hazard ratio usually in the same range between them. Even in patients with thrombosis, vascular access thrombosis, if we can have the roxadustat, the percent of vascular access thrombosis or thrombotic events are equivalent in both the groups. So the clinical pharmacokinetics, it could be taken orally. The plasma half-life is around 16 hours. It's totally plasma binding, so it is not dialyzable. In many of the clinical researches discussing the efficacy, they noted some of the complications of patients with the roxadustat, like unexplained hyperkalemia. So we have to rethink about that in the mechanism of roxadustat and the effect of hyperkalemia. Probably it is on observation rather than a tool, but however, in some studies, or in the frequent studies, we have to think if they have a direct role of HIF and potassium homeostasis. So this one of these studies are done in China and registered of the roxadustat for many months of treatment, comparing the placebo and roxadustat, and the finding that patients with roxadustat is increasing in the change of the baseline of hemoglobin rather than the placebo, and as well the importantly in iron, IV iron is decreased. But hyperkalemia is reasonably higher than in the placebo as well, metabolic acidosis, and probably this is an observation, not a direct cause. Many studies are for that recently published within the last couple of years, controlling that in conclusion, both HIF and ESA, like dapstat or placebo, are effective in treatment. They increase the hemoglobin at the same way of erythropoietin, but they decrease the hepcidin level sharply. And in patients with high CRP, they were swollen, with importantly decreasing in ferritin and increasing the iron delivery to the bone marrow. All of these are the same results and the same conclusion consistently in patients with dialysis dependent and standard or stable and incident dialysis dependent as the same way. Putting to that on the future, it may have a protective against acute and chronic kidney disease, can prevent retinopathy prematurely or retinal detachment by angiogenesis, can be inhibitor of cardiovascular disease, accelerating bone and tendon regeneration. I memorized that sodium glucose co-transporter, when had been introduced for glucose treatment, we are now treating patients with diabetic kidney disease and maybe as well in synergistic effect with RAS, probably hypoxia-inducible factor in the following years may have as well a role on such a patient. Coming to the few slides at the end, the dogma of additional treatment for anemia. It is the clinical life. We used a lot of dogma for treatment of anemia, including L-carnitine, folate, vitamin B12, and vitamin C. What is the rule? L-carnitine or levocarnitine is a small molecule produced by the kidney, and it is completely dialysable. L-carnitine by enhancing mitochondrial delivery of fatty acids in the mitochondria, so they share the energy inside the cell. Also, L-carnitine is dialysable. It is 162 Dalton, and it's a quantity amine that is not bound to albumin in plasma and is stored primarily in muscles. The mechanism of action of L-carnitine is it is just a shuttle for introduction of the long chain fatty acid inside the cell, especially the muscles. First, carnitine replaces the CoA of the fatty acid, so transferring the fatty acid molecule inside the cell. Once introduced inside the cell, it alkyl carnitine transport, it gives the mitochondria the free fatty acid to be beta oxidation. The primary carnitine deficiency will induce non-acidotic and non-hypoketotic. It's hypoketotic hypoglycemia on the reverse of hyperketotic or diabetic ketoacidosis. Failure to thrive, hypotonia because the muscle and cardiomyopathy possibility. It increases the ATP energy by the same way that it is just a shuttle to introduce fatty acid inside the mitochondrial matrix to produce the energy required. In hemodialysis patients, a lot of studies are conflicting studies. Some improve and some have no in meta-analysis. The present meta-analysis, some meta-analysis gives the insight of beneficial effects and some others are not. Taking in consideration, there is no risk of taking L-carnitine, so it is our clinical habits to prescribe L-carnitine in patients on dialysis because it is dialysable and it improves the muscle recovery, and the patient probably may maintain in patients with hyperresponsiveness to anemia and ESA may get benefit from L-carnitine supplementation. A lot of studies on this way, and potentially ESA-resistant anemia, cardiovascular disease, intradiabetic hypotension, and in patients with muscle weakness. They are giving that to the horse because the horses and the L-carnitine are important. Definitely, we are not looking for our patient to be a horse. We need live longer and stronger, and the potentiality of that can improve, but there is no conclusive data from each paper that the meta-analysis has different approach. Even they give that in 2003 National Kidney Foundation, most notably ESA-resistant anemia, and then in 2006 the updated National Kidney Foundation use of L-carnitine in the management of anemia is of no value, and later on the US Center applied L-carnitine applied for patients on dialysis, and they put the rationale that the patient plasma free carnitine is low and have an ESA-resistant anemia, and they give that by intravenous flow. So L-carnitine in hemodialysis, even in the guideline, is not prescribed. More of that, as well others, like in vitamin C, it is not of value to give vitamin C, although it is dialysable, but the patient can take its vitamin C deficiency by normal nutrition. My experience is that sometimes it helps in patients with hyperferritinemia and improving of the erythropoiesis in a very small dose, because we know that vitamin C can induce oxalosis, but in a very small dose, like 500 milligrams every other day, most dialysis, to my opinion, can get benefit. Vitamin B12 and the folic acid, still controversy. Folic acid because it controls the homocysteine level and the cardiovascular event, but even patients with folate supplementation did not get of the benefit of that. So there is a strong inverse correlation between serum folate level and the plasma homocysteine, not achieved well in patients on dialysis, and you usually need huge doses, given multivitamin B6, B12 of no rationale in patients with CKD anemia. And coming to my last slide is the conclusion. Anemia management in pre-dialysis CKD patients, we have to do a great attention and big challenge to overcome all the monitoring and the treatment option. And pre-dialysis anemia at the start of dialysis is very painful and will have worst outcome. ESA, including EPO and hypoxia-inducible factor, is a bidirectional way of risk and benefit.